So for those either in the room or on the outside, you don't see Jay too often. He dials in. He tells me he got blamed a couple of weeks ago for taking control of the session. So Jay was a fellow here a long time ago. He probably remembers the year. I don't. And then he was in the Air Force for his career. I think he was like the highest rank you can attain in the military and be a physician. I remember him telling me a story one time of briefing Dick Cheney, Vice President Dick Cheney, who didn't seem like a very nice guy to me to be in the same room with.
You got into trouble for making those kinds of comments.
Yeah, well, the people now are worse for making comments. So anyway, he's always had a passion for computers, and he worked, after he left the military, worked as a physician with NAC for a couple of years, at least part-time. And now most recently, he's just brilliant behind the scenes in writing computer code. So every time things change, we have to have an update. He literally writes the new computer code to make it user-friendly for the computer system over at NAC, as computer-friendly as things can be. So he was the perfect guy to talk about computers in medicine, the good and the bad and the ugly and whatever other title he gave it. So Jay, it's all yours.
All right, thanks, Lynn. I'm not a real expert on the basic program, but what I have developed an affinity for is with the Centricity product by formerly GE and now owned by the Athena Corporation. They have the ability to use something called MEL, or Medical Evaluation Language, so you can customize and write your own forms that interface with your EMR system and make life a lot easier, hopefully to reduce number of clicks and to capture a lot of structured data. That is not the case for programs such as Cerna or Epic, where if you want customization, you really need to do additional contracting with them. Their people put together what they think you want and then add it on to their system. So what I'm going to talk to you today about, as soon as I make sure I figure out how to advance the slide. Is basically electronic health records or electronic medical records. Both of those terms mean exactly the same. And what are some of the pros, the cons, and what are some of the issues that you need to be thinking about, especially if you're not happy with your system and you think you might want to change? I have nothing to disclose regarding that. Now, there's a lot of terminology that's involved in EMR systems, and so I added at the beginning of the slides just kind of a glossary of some of the terms that you will be seeing with EHR systems. This all started with the high-tech initiative in 2009, done by the government, saying that we really ought to take medical records, put them in an electronic interface so we can pull data, we can do more research. They also have ways of monitoring you as a provider, giving you incentive pays, and different things through CMS and medicine. But this is for your reference if you're looking at the slides later on, what some of these terminologies mean, and especially because if you start reading the literature, most of it's using the abbreviations. In a typical EMR system, it has to deal with patient demographics, your progress notes, and that can be in many different forms, your problems, medications, allergies, directives, what the patient wants to do, typically vital signs, past medical history, social history, immunizations, lab, and imaging type data. A lot of the data that goes into the EMR system needs to be discrete data, which means it's put into kind of a mailbox or a pigeonhole that can then be accessed later on with a search function. Unfortunately, a lot of EMR data allows a ton of free text, and free text is almost impossible to search if you're doing a research type product. There are systems such as Epic that will take your free text in your progress note and then using certain AI technologies will extract out different terms and different things that you said using different algorithms and then push those into those discrete cubby holes. A lot of EMR functions that are important to the system and will make your life a lot easier. One of them is called CDS or CDSS, and these are a clinical support decision. This is where the computer programmers and the different systems can take what is standard of care, can take what are the practice guidelines, and give you cues to alert you as a provider that you may need to consider a particular diagnosis or a particular medication for a patient with a particular diagnosis, or even alert you that if you are going to have a claim that goes to a third-party payer and get paid, if you have the primary diagnosis, you also have to have some secondary diagnoses that go along with it. A good example of that is asthma patients that are also a smoker. Most third-party billers now require that if they are a smoker, you also have a diagnosis of tobacco use history or a tobacco user, not what they're smoking, whether they're a high or a low amount smoker, but just the fact that they're using tobacco. And those two have to be married together often, or otherwise the claim may be denied. Other things that are going on, typically the CPOE is the area of an EMR system where you put your note, your progress note, what medications you're giving the patient, what you want them to do, any imaging that you're ordering, other lab orders, and instructions to the patient. This is typically used by a lot of folks like a SOAP note, but not necessarily in all different systems. It depends on the system you're on. But EMR systems have been good. They've reduced the number of errors, especially in medication, because now you no longer have that handwriting by the provider that nobody can understand. I think that may be a requirement to graduate from medical school, how bad your handwriting is, but now with the EMR system, at least medication errors have decreased by about 55% because it's much clearer going to the pharmacy and what's going on. E-messaging to the providers is also important because then you can communicate much more directly. And then we won't go into too much on billing and charge capturing for the third-party payers. Preventive medicine has definitely improved with EHR systems. When you get a pop-up for your providers, your nurses, saying, hey, by the by, this patient has not had their flu shot, or this patient's over 65 years of age and has not received a pneumococcal vaccination, giving you those alerts so the staff can then address that with the patient and take care of those public health issues and doing better preventive care. There are a lot of EHR products on the market. They're basically formulated either for a hospital-based practice or a small clinic-based practice. And this slide shows you kind of the most popular ones for either category. Epic is used by the University of Washington. I think Cerner was, I don't know, is Cerner still used at Children's?
Still used at both. Yeah.
Okay, so Epic and Cerner are the two big hospital-based programs. There are over 500 different EHR systems out there right now. Unfortunately, quite a few of the very small ones are having to drop off and stop marketing their product because they are not being meeting the criteria to become certified to continue on, which CMS each year publishes new criteria that you have to meet in your EHR system to stay certified and receive reimbursements and incentive pays from CMS. On the clinic side, Epic is still used as in a lot of clinic practices. GE Centricity has about 5% of the market. That's the one that's used at Northwest Asthma. And then there are other ones out there. And so this just kind of gives you an idea of what the market share is.
Okay, that, go back just a second, that raises to me one of the big problems with this. You would think you'd want a unified system nationwide, practitioners could talk to one another and exchange. So with all this diversity, is anybody making an effort to unify this into one system?
Yes, and that's called a health information exchange. Big companies like Epic have their own add-on module, which is a HIE, Health Information Exchange, and it allows you to take data from an inpatient visit with the patient. It pushes that data directly into your EHR system. Unfortunately, these HIE systems are add-ons to the primary product. They cost money, and a lot of practices haven't added that additional investment. So a practice such as Northwest Asthma could pull all of the data from patients admitted to Children's, University Hospital, Providence Hospital, by having a product called Hospital Connect, which is the Centricity version of an HIE. It extracts data using a special protocol called a FHIR technology, and I'll talk about that a little bit later. That's a FHIR API. It pulls those discrete data elements and then pushes it into the discrete data elements in your EHR system. It is there. It does cost. It is an add-on, but we're getting there, and Congress has mandated that in the next several years that we have to have much better connectivity and less expense to the EHR systems for providing that technology.
Jay,
Yeah,
we have Epic Clinic and it won't talk to the Epic Hospital without buying a separate module.
that's exactly right. And basically, the big EHR groups have all these technologies, but no, you got your base product. If you want this, you need to pay for an additional product or another additional product. All these add-ons, there's quite a third-party market and a primary market for those.
It's just sort of sleazy that the same company won't even talk to itself. I thought that was
Right.
interesting.
What about between outpatient? I mean, very often we need notes from an outpatient. Let's say we have GE Centricity and somebody else has all scripts
Right.
in an office a mile away. Can they talk to one another?
They cannot talk to one another unless they have the interface protocols. The only way they can really talk to you is to do a paper copy, a PDF file, and fax it to you right now.
Yeah,
And that's ridiculous.
Yeah.
And that's what we're actually trying to get away from. So let's go into some of the good, the bad, and the ugly of EHR systems. Well, on the good side, EHR systems have improved medical care because by giving you intelligent alerts, telling you, hey, have you thought about this patient with diabetes that you haven't done an A1C in over 2 years, and or this patient is a smoker, are you addressing his smoking status? Asthma patients, are they on, have they been using oral steroids? Do you need to make management decisions? There can be pop-ups and alerts depending on how that EMR system is programmed that can assist the provider. It's good at organizing details as long as the data goes into structured little cubby holes and can be later retrieved. Again, we talked about medications, no longer bad handwriting, so you get a much clearer. There are some issues, and I'll talk about those and the cons on medications. Appropriateness of care, you can use the templates that a practice can design for themselves and implement into their system, or they can contract out. Unfortunately, with the clinical decision support modules, a lot of the EHR companies are very reticent to implement them themselves and kind of put that burden of responsibility on the providers or the practice because they don't want to be the deep pocket should a patient sue a practice and they said, well, we base this on this particular CDSS that the company has supplied. So that can be a significant issue, and I'll talk a little bit about that later in the legal aspects. They do save time for the patient filling out forms before they have the office visit, if they fill out the form, such as using a portal or a tablet in the waiting room to fill out an ACT score before the provider sees them. Although that can also take time if your patient is kind of slow and slow up your workflow too. So this gives you kind of an idea of some of the issues for improved patient care. Other advantages, if you have paper records, you have a huge storage space to maintain those records for 10 years based on federal requirements. EHR eliminates that, and now you have a much smaller space requirement because of your server farm to host your data. And it's interesting that in the days of paper, about 1 in 3 charts never made it to the physician during the visit because A, they couldn't find it in the stack, B, another physician had it in his outbox to finish his note and sign off on the chart, or it was in another little cubbyhole. So some of those things have improved by having accessibility. Plus, with EHR systems, unfortunately, you can dial in at home and finish your chart. Or if you're on the road and a question comes up, you can actually review what's going on with the patient and answer a telephone call if appropriate. So the computerized order entry system has been a real help. The biggest problem right now is making sure that you can capture the structured data out of it so it can be used later on. Other improved outcomes, the ability to do research with EHRs has vastly improved. Now I can go in if I wanted to and find every patient between ages 55 and 65 that has mild persistent asthma, is on a LABA, and has used oral steroids if I want that particular criteria for a patient in a research project. And the reports modules can spit out that list of patients that you could then contact if you, for example, you wanted to invite into a research study. So that has been extremely helpful in medical research.
Jay, 10 years in, what percentage of, especially private practices, I assume virtually every hospital right now has to be on EMR, but private, how many doctors have just resisted doing this?
It depends on who you read, but right now it's approximately, the last article I saw was 83% of practitioners, and that excluded, I didn't see the data for a solo practitioner, but 2 or more physicians in a group, about 87% now are on some sort of EHR system, including some systems that the practitioner themselves have kind of taken a database and created their own, quote, little system, although that's going by the wayside because those aren't standardized or have been certified by CMS.
And what's the implication economically for those who don't accept it? What does the government not pay them for the thing?
Well, if they have no way of extracting data for meaningful use, and to be able to say, I have these patients, we did the following things with them, we met the criteria for the 6 items they're reporting on, that can be a very time-consuming and expensive product to submit their meaningful use criteria and see if they will get an incentive pay. There is a penalty phase that's going to be kicking in on meaningful use in MIPS, where if you're in the lower 50%, you're going to lose money on these incentive pays. If you're in the upper 50%, depending on where you're at in that stratification, you will get more or less incentive pays. So yes, it's really forcing everybody to eventually become integrated into the electronic system.
And that's federal money. What about insurance payers?
Third-party billers, or third-party payers are becoming more and more fussy about claims, and having an electronic system, which I'll get into in a little bit, will facilitate better claims processing. If you're doing it manually and you have mistakes, those are all types of things that can have a denial of claim, especially if you don't have the right CPT codes, you don't have the right CPT codes in the right order, or you tag in your primary, for example, asthma CPT code J45.XX, and you also did a spirometry, but that's your first diagnosis, you put the spirometry. They may not pay you for a visit, but they'll pay you for a procedure, and that's a lot less reimbursement for that particular encounter. So, and this just gives you kind of an idea of some of the things that can do increased revenue if you have an EHR system. All right. This is what a lot of people want to know about. What are the bad and the ugly of EHR systems? Okay, delays in documentation. You're the physician, you go in, you have 15 minutes to see the patient, you're typing like crazy on your laptop or scribbling on a piece of paper, and then you have to leave. When do you get that data pushed into the EMR system? Oftentimes that's after hours, during your lunch break, or during pajama time when you go home and have to finish up your charts in a timely manner. When written notes were done, they were usually briefer, more succinct, and to the point. EHR has generated a whole new generation of very affluent, verbose, and worthless, yeah, verbal diarrhea into the charts. And so that is an issue that has to be looked at. The other problem is if a chart is open on hold and another provider then goes in and creates their own visit, they may not have access to everything in that chart, especially certain problems and orders. Until those have been signed off, the next provider down the line may not have access to that data, and that can influence quality of care. Empty data fields is a really big deal in EHR systems, and especially if people use a phenomenon called copy and paste. So if you're pulling history from a previous visit and pulling it into your chart to populate certain data fields, but that was not updated between when the patient was first seen and when they're now being seen, that can cause a problem. A good example of that is you saw a patient, they were referred for surgery, they had the surgery, but that never got updated into the EHR. It gets pulled forward, and in the little block, any surgeries, it will say, because there's nothing there, because nothing was previously entered, patient hasn't had that surgery or no data available. That can adversely affect clinical care. It's one of the big problems with copy and paste. Also, third-party payers are becoming much more astute when they see a series of 4 or 5 clinic visits and the history of present illness with maybe a 1 or 2 words change, sees exactly the same wording because it was copy and pasted from the previous visit into the next visit, not really updated, and again and again and again. Also, if you get audited, that can be a major issue for fraud and can be significantly expensive to a practice. Also, lists need to be updated. Medication lists, problem lists, directives. Who in the practice is responsible for doing that? Is it the nurse and the MA? Is it the provider? Is it a combination of both? The front desk that has some input into some of that data also. So those are important that everything be kept up to date. This is just a kind of a look at and a snapshot of broken records and some of the causes for a record having problem. This is a study done by the Kaiser Family Foundation. Oops, typo there, sorry. And but you can see the patients are complaining about what they saw in their medical record when they went on the portal and pulled it up. Incorrect medical history was about 9%. Incorrect personal information, about 5%, saying the patient is a smoker when they weren't a smoker, as an example. Incorrect lab tests or the wrong lab tests from a different patient somehow getting into that particular patient's chart, and billing errors. E-messaging. It's a e-messaging is a
How long does this go on?
and definitely that loop.
So you retire, man.
So e-messaging is a good way of talking with other providers, but it has also had a downside, and that is in the old days when you picked up the phone and you called a third-party payer or you called another physician, you could express emotion, you could express anxiety, fear, you could express your demand that something be done. With an e-message, it's just what you read on paper. So the emotion, the intensity, the absolute urgency of getting something done is not there. Plus, you don't know on the other end if the patient, the other provider actually, or their staff actually read the message or received the message, unless you try and get a return receipt, but that doesn't always happen. So e-messaging is not a all or none good thing. There are both pros and cons for that. Unintended consequences. Again, eye contact with the patient, the joy in medicine, dealing one-on-one with your patient, but spending time looking down on your computer tablet, not even paying attention to what the patient visually is looking at, just hearing what they're saying can be a real problem. So, and then EHR systems have changed the power structure in organizations, especially depending on who in the top of the organization wants one particular system. The IT department has become a much more powerful organization, and really when you're making a decision if you're going to buy an EHR system, that's the last person you really want to have making the decision. It should be the providers making the decision what they want, how they want it, where they want it, and then the IT should be able to make that happen based on that criteria. Not the other way around, saying the IT saying, oh, this is a great system, it works on our servers and compatible with this and that, and you docs, you just need to figure it out. Backup copies can also be a problem if you have a natural disaster, power goes out, earthquake. How are you going to deal with your patients if you can't access those records? HIPAA violations have actually increased in some respects with EHR systems, especially because stuff still gets printed out from the EHR system. It doesn't get properly taken care of because it's not going, it's a loose piece of paper. It gets tossed in the trash, HIPAA violation. It's left on a desk or someplace where somebody else may see it. People snooping in EHR systems. So your great aunt was just admitted to the hospital and you're a provider in that hospital. Is it ethical for you to go in and look at her chart without her permission? No. That's kind of basically a snooping type thing. Accidentally going in and looking at a chart because the permissions were not set properly for somebody such as an MA or staff to see a confidential record, somebody that has a disease that is in, such as depression, and their record has been marked confidential, only the practitioners can look at it. Access to third party is also a problem. Oftentimes the EHR system may spit out an entire record at the request of a third party payer, such as a disability insurance, but the patient never gave permission in writing for that entire record to be sent to that disability insurance, and suddenly all types of problems occurred. That can be a HIPAA violation. Unfortunately, criminal sabotage is out there. Ransomware, you know, very few systems are 100% secure, if at all. And speaking of problems, 58% of adverse actions on your EHR system are actually done by an insider, not the outsider, not the hacker. Although the hackers don't even need to get a hold of the data to make your life an absolute hell. All they have to do is encrypt your database and demand ransomware, a Bitcoin or something, to get that the data back. Unfortunately, not everyone gets all of their data back when that's happening. Provider burnout. In the top 5 reasons for providers burning out, an EHR system or integration is somewhere in that top 5. Sometimes at the top, sometimes number 5, but it's always there. So a lot of different causes for provider burnout, increasing the work time. And there was a recent study done by the Federal Agency for Healthcare Research. They were looking at what causes provider burnout, such as family responsibilities, time pressures, chaotic environment, low control of the pace, and then the EHR record. It's interesting that people that spend a lot of pajama time, quote unquote, finishing up their clinical records, i.e. they're at home and trying to finish their records, that is a significant contributing factor to burnout. Physicians that don't have enough time to complete their EHR charts within the office environment, they're 2.81 more likely to show burnout symptoms. They're about 1.93 times more likely to show burnout if they're having to do EHR issues at home, and about 2.44 times more frustrated and burning out than they would be if a patient says, oh, I really love my EHR system.
What's the error rate for physicians who complete their charts at home?
You know, I didn't find a good study on that, and I was looking for that. There are some, the Kaiser Family Health Foundation has something in the works, but I couldn't find that particular article. But yes, that can be a process. If you are fatigued and tired and burned out, errors can be made.
You don't remember.
All right, another problem with EHR systems, way too many clicks. And on the just to do a simple thing like append a note to the chart can take 18 seconds of your time. And they did a study on this where they actually watched and looked at people. It takes time to hover your mouse over the item you want to click on. It takes time to click it. If you're doing a drop-down list, it actually takes about an average of 4.5 seconds to make the decision of what item you want in the drop-down list and then click on that. A lot of EHR systems, especially if they have a lot of click boxes, can take up significant time. Now, there are some improvements in EHR systems that are coming out on the market where you can minimize those clicks, or with a single click you can do about 8 or 9 or 10 actions, and these have to be designed in the EHR centricity. There's a product called C-Quick that allows you to design a certain type of pop-up template that will give you a choice of maybe 8 or 9 click boxes for a patient visit. For example, a patient comes in and has conjunctivitis. So you type in your CPOE the diagnosis of conjunctivitis. The first box that will pop up will say, is this viral conjunctivitis, nonspecific, or allergic conjunctivitis? If you click, for example, the allergic conjunctivitis, the next pop-up, so you have one click, will show you, you can say what's going on with the patient, what type of symptoms they have, if you want to prescribe a medication or an eye drop, and whether you want to give them a patient handout. Well, the patient handout box is already pre-clicked because you're going to give it to them. If you click on the medication, you'll get a allergic conjunctivitis specific medication list, so those items that are appropriate for that one diagnosis, and then you can choose the one you want, the eye drops that you want, and what you want to do. So within about 5 clicks, instead of about 30 to 40 clicks, what you've done is you've documented a note in your CPOE, you've added the medication, you've added patient instructions to what you're going to hand to them at the end of the visit automatically. You've already put the correct problem in the problem list, not just nonspecific conjunctivitis, but conjunctivitis allergic, and right eye, left eye, or both eyes. And so with a minimal number of clicks, you've been able to do a lot more documentation and get on to the next issue with your patient.
You know, Jay, just thought of this while we were talking. One way physicians have tried to get around all of these downsides was to have scribes.
Right.
And we tried that at NAC. I don't think it worked for anybody in the end. We all gave up on it, and generally because the scribes did not have adequate skills to write a good English sentence.
Yeah. Interestingly enough, the use of scribes will probably be coming back into vogue with the AI interfaces with EHR systems. And with AI, there are a lot of companies out there now that are developing AI algorithms to take your free text and pull out discrete data to push into the EHR system. And what the object is for you to be able, ultimately, maybe 10 years down the road, to walk into a patient's room, click the mic button on, just start talking to the patient back and forth. It's captured into something like a dragon speak type of protocol, and the intelligent AI intelligent algorithms start parsing out bits of data, pushing them into the right cubbyhole, and giving you a summary. And when you walk out of the office, up on your screen shows what you talked about, kind of the history of present illness, any social or past medical history, the things you found on your exam, because you say, okay, heart was clear, lungs, no wheezes or rows, all that gets captured. That's out there, but it's a long ways away yet. It's still in a very primitive stage.
So not a human scribe.
Not going to be a human scribe. It's actually going to be an intelligent Dragon Speak-like product with AI on top of that, pulling out those discrete data and pushing it into the EHR system. Okay, where are we at on time? I don't have a watch.
You got 20 minutes.
Okay, great. So again, too many clicks is a big problem, and that's one of the most frustrating things causing provider burnout and losing the joy, really, of medicine on that one-on-one interface with the patient, because you're spending much more time looking down at your laptop rather than face-to-face with the patient, or even scribbling on a piece of paper and then doing it later when you get out of the exam room. Legal issues are still a big problem with EHR systems. And this has to do with the EHR program itself. Are there glitches in your particular system that may cause an error to the patient, such as it's pulling data from the wrong patient into that visit because the chart and different parts of the chart weren't properly locked on the last patient's encounter? You walk into the room, open the chart, and some labs from the previous patient's visit happen to get pulled in. This has been a factor in several EHR companies that actually have gone out of business due to mega lawsuits. Is there a sign of fraud? Because it's so easy to do things in EHR, have you upcoded a visit that wasn't really truly documented, and so when it gets to the third-party biller or an audit, they're saying, wait a minute, this is not a level 5 visit, this is only a level 3 visit, you didn't do thus and so, although with your click and point and hitting an all negative button or something like that, it looks like you may have done that. So there are issues there. Gaps in interoperability, we already talked about. Do these EHR systems talk to each other? And on the add-ons that you buy for your system, are they truly working seamlessly? What I call the web of secrets, and this is probably very few people in this room, when they first went on to an EMR system, really looked at the contract in great detail to be aware of everything in that contract, what the vendor was going to provide you for your EHR system. And one of the things is oftentimes in that contract that you may not be aware of is what I call gag clauses, where if you really hate your EHR system, your contract prevents you from going out on the web and public speaking and everything and saying, this system really is lousy for these reasons, bad-mouthing it as you're trying to switch. We'll talk about switching in just a minute and some of the pitfalls going on there. All right, EHR systems are not cheap. When you first get the system, it costs a lot of money to set up your data center. Every user has to have some sort of way of interfacing with it. There's disruptions to workflow and patient privacy. Initially, they're saying, oh, what's going on here? There are a lot of issues. Once you have a system up and running, you have to replace your hardware on a regular basis. It goes obsolete. Microsoft, as an example, their SQL server that a lot of EHR systems are using to run the database. If you have an older version and they no longer support it, it doesn't have the security patches, you're going to have to upgrade that software, that hardware, etc. There's all types of licensing issues, upgrade issues, API add-ons, training of your staff, help support, etc. So all of these things actually adversely affect a practice as far as overall income. Vendor support is extremely important with an EHR system. How well, if you have a problem or you don't know how to do something, can you get help other than just your IT person who may not be totally knowledgeable And almost all of the large and small EHR vendors use companies, support companies in India or elsewhere to do their help service calls. And if you have to spend a half an hour on the call just explaining a simple problem because of a language communication issue, that can really be frustrating to either your staff or to yourself. Using a value-added resource, they call these VARs, you may get more responsive because you're paying for a kind of a different level of support, but VARs are often more responsive than the EHR vendor themselves in the support type arena, and that's the decision of practice has to look at. Okay, in the last part of the talk, I'm going to talk about some issues you may not have thought about in general on EHRs, and that's what happens if your database has gotten too big and it's so slow that it's taking forever to load the patient and get into the room and see the patient, or one of the practitioners is retiring, or one of the practitioners says, I'm out of here, I'm going to a different practice, I just can't work in this environment, but I want all my patient records to go with me. Or a practitioner is retiring, or you want to archive data because when you load a patient visit, everything about that patient is pulled in unless you have set an archive flag, let's say at the 2-year point. So when you go into the patient's room, you want that chart to load fast and be able to see relevant data, probably for maybe up to the last 2 years, but I'm not sure you want to see data right away from 10 or 15 years ago on that particular patient. And that's where archiving comes in. All right, so some of the reasons why you may want to work with your clinical data. You want to migrate to a new EHR system. You want to clean up your database. You have to purge old records. Patients that have died, it's been more than 10 years, you no longer have to maintain that record. Get them out of your database because that does slow things down. You want to split your databases because let's say you have a large clinic and you want all your surgical data in one database system, you want all your medical stuff in another database. I'm not sure why you do that, but that's kind of an example. You're going to split your database because of divorce, somebody's leaving or they're going to a different practice, whatever, and you're going to shrink your database to make it perform a lot faster. Elements that can be moved. Not everything in your database can be moved. Number one, the database is usually a proprietary system. It's known as a relational database, which means it's a database with maybe hundreds of interlinked tables. So you can have a table that just says patient ID, and there's a unique ID that's given to the patient, and that will then link to medication lists, problem lists, history lists, and it's a whole cascade down, but it's all interlinked and all these tables, but not everything can be migrated if you don't know the proprietary structure or the schema of that particular database. Who owns that database? Do you, the provider in your practice? Is that what was in your EHR contract? Or does the EHR vendor actually have ownership and gives you access to that database? Big distinction, and that's often not something people see in their contracts or read in their contracts when the vendor is saying, yeah, we got better than sliced bread system, you need to take it, just sign on the dotted line and we'll put it into your practice. So that's something that people should be aware of. Things that can be transferred though are discrete data elements such as clinical directives, allergies, PDF files that are attached to the patient's chart, scan documents, immunizations, and medications, observations, lab tests, orders, etc. But it has to be either discrete data pushed into discrete data in your new system, or it has to be free text, such as a text file or a PDF file.
It is a little off topic, but just listening to that. 10 years in, we already have the most expensive and one of the worst healthcare systems in the world in this country. Has this made medicine more or less expensive for the nation in general? And the An associated question, how are other first world countries, the UK, Canada, dealing with this?
They all, taking your second question first, most countries now have electronic healthcare systems for recording patient interactions. Whether it is more cost effective to healthcare, in general, yes, but it may not be the provider that's the person getting the benefit. The person getting the benefit may in fact be the third party payer, because they are seeing less errors. They're more able to deny claims because you didn't have everything needed to support that claim. There's less redundancy in tests. So Dr. A, Dr. B, and Dr. C all aren't doing the same test, when one test, if it's available to all three, you can see that and not do duplication. So overall, it has improved, but not necessarily always down at the practice level, where it sometimes can be more expensive.
So globally, for the whole nation, it's made American medicine less expensive, you're saying?
Yes,
Yes?
but not necessarily. But it's not equally distributed. No. Okay, just in the last few minutes, and then we can do some more questions. Transfer methods. There are a lot of different ways to transfer. But if you have a proprietary database and you're going to another proprietary database, you may have to hire a third-party company that has the ability to do different extraction methods to pull that data out and push it in. And then you have to determine exactly what you want to be pulled. Not all data really needs to be pulled. A lot of different reasons to migrate. We already talked about those briefly. One of the things that you also need to be aware, if you're switching from one EHR system to another, you may still have to pay for your old EHR system for a period of time. If there are, for example, accounts receivable on patients, until those have all cleared the system, you're going to have to maintain that old system even though you have a new system, because that data doesn't necessarily get pulled over. If you have to maintain records for up to 10 years, and can't pull the entire record, you may still have to maintain your legacy system. That can be expensive. So a lot of different issues that come up there. Splitting a database and a database divorce, that can be a tricky issue. There are legal issues involved if it's not an amicable, basically divorce when a provider leaves the practice. So you have to decide what data gets to be pulled with that provider. How are you going to do it? Are you going to duplicate your database, give it to the provider, and then delete the things that aren't relevant to him in his database, and delete his stuff in your database? That's one way to do it. Or are you going to just push discrete data over, or other things? And what system it's migrated to makes a big difference. A lot of the small EHR systems, their databases are very proprietary, and that does cause complication. I was recently at a conference where a firm, I think it was called MDEMR, that specializes in moving data from one EHR system to another, typically says that the process can take anywhere from 2 months to 6 months to fully migrate data from one EHR system to another, depending on the size. And when you're talking about terabyte database systems or multi-terabyte database systems, that can take a tremendous amount of time to discreetly pull that data. They also talked about the cost of doing that, writing the custom interfaces to go in, depending whether you're using an Oracle database or an SQL Server database, and how to pull that data out of the data tables and link them. That can be anywhere from a very primitive type EHR system, $10,000 to $20,000, to a big 16 provider practice, anywhere from $500,000 to $1 million to do those types of data migrations. It's not a cheap process. I was kind of aghast when I heard that. Purging records does make good sense, and this is done by your local IT people or your vendor, and that can improve your database. You can also improve your EMR functionality, make it more responsive, because you're not bringing in records that are obsolete or not germane to what you're currently doing. Getting rid of old legacy records or pushing them into a storage database archive is important. And then you want to get rid of records that have already sunsetted out. You haven't seen the patient in more than 10 years, the patient expired, and you've maintained the record for the required amount of time. You don't need that in your active database. There are a lot of different ways you can do the purging. You can just do partial, remove the financial information, move some clinical or demographic information, removing the obsolete charts, and then you can also improve its performance. Archiving does work. We did that recently at NAC and improved some of our loading of patient visits considerably by getting rid of almost a quarter of a terabyte with the data, pushing it into the archive. Archive records are not gone. They're just in an archive, and if you actually need to see that data, you can access it by doing a couple clicks and pull that back into the current patient visit. So that's just something to be aware of.
What does a terabyte mean in quantity of data?
What's a good example? This room would be like maybe a gigabyte of, or I mean 1,000 gigabytes of data. This whole building would be like a terabyte of data. It's a lot of data, and for every record you have on a patient, that's not just a few kilobytes of data, and that's not even just a few megabytes of data. That can be up to anywhere from 1 to 10 megabytes of data, depending on labs, orders, PFTs, different surveys, ACT forms, urticaria questionnaires. All that adds in to a particular patient, and then every time you see them, that's adding more and more data. One last comment on EHR contracts that something I came across is, again, who has the absolute authority to own your data? And how is that written into your EHR contract? Is it the vendor who owns the database and the data and gives you access? Basically, you're paying for that access by your licensing agreements, having the program, etc. Or do you actually own that data and can take that database and pull it? Will the vendor charge you extra to take it out of their proprietary system and give it to you in a usable format that you can use in a new EHR system? These are all questions that oftentimes don't get asked and can cost lots and lots of money. The future we talked a little bit about in with various questions. The use of the Health Information Exchange is important. It is an add-on, unfortunately. There is congressional legislation that's being looked at and CMS rules to make that integrated and part of EHR systems, not an add-on, and that communication has to be there. The technology has already been written using the FHIR API, which stands for Fast Healthcare Integration Resource. It's a protocol that tells you exactly in it. For anybody that understands programming language, it looks a lot like XML5 and how it pulls data, but it's very scripted on how you can pull stuff using different scripts into a format and then push that into another environment. Artificial intelligence is probably the last area. I think it's still 10 years plus off, but there is a lot of excitement in the AI technology. There was recently a large conference down in Las Vegas on healthcare AI, and with different vendors talking about how They want to facilitate the physician provider using probably some sort of a free language text that gets extracted into a machine text, then gets analyzed by AI algorithms and pulled into discrete data and put into your EHR in a logical format that you can then review. So that,
What you just said, those words mean you talk to the patient and the computer writes down the words.
that's exactly right. You face to face with the patient, you have a conversation, you bring up things, you're doing your exam, but as you're doing it, similar to the scribes right now, if a scribe is in your room and the doctor, like the dermatologist says, okay, I see 3 AKs, you got a nevus here, you got a mole there, and the scribe is writing that down. You're doing the same thing, but you're doing it face to face with your patient, and you're having a discussion back and forth. That data is extracted, analyzed, and pulled. They're not there yet. There's a lot of things that have to be done. There's a lot of medical legal issues, but it's a possibility.
There's something called Augmentics. It's already out there. It's like a Google Glass.
Right.
And you can actually see, you can say, pull up the X-ray from 2015. It shows up, and you're actually talking to the patient.
Yes.
And it also writes down the notes.
Yeah. So I would have loved to have gone to that conference. I read about that, but you're right. There's a lot of stuff on the horizon. How it gets implemented, integrated, and its cost, whole big different issue. But there is hope on the horizon. All right. Other questions?
Seems like we're really,
back, huh?
What?
There's no going
Unfortunately, there's no going back.
Jay, it seems like we're really vulnerable for the hacking malware, and we're just going to be
Yeah, no,
so vulnerable with
that
this.
is a big issue, the hacking malware, and especially healthcare providers and small practices. It's real easy to get a phishing email, and if your staff is not continually peppered with reminders, don't open. I mean, just the other day on my U of W account in the trash bin, I got something. Click here for $100 Costco gift certificate and just fill out this information. Now, was that spam? Was that a hacker? Was that attached, if I clicked on that, to some malware that would load on my computer so they could start to get access? Whole lot of issues there. Once a hacker gets into your system, they don't really even have to access your database, be it, and databases are encrypted. All they have to do is put an overlayer of encryption that you can't break and say, okay, pay up, or you don't get your data. And it's not guaranteed that you will get all of your data back once it's been messed with by hackers. So unfortunately, that's something a lot of practices don't pay as much attention to as they should, is the security of the user, their IT farm, their network, whether it's cloud-based or not, etc. And all you have to do is get hacked. It gets out into the public, and the reputation of your practice just went downhill.
What happens when your computer goes down when we're so dependent on all this stuff? I mean, are you just totally screwed? Which is what happened to us.
Well, one of the things that you can do is have a file cabinet, basically, of some paper forms that have basically kind of the old way we used to do business. You can write that. It can then be scanned and attached to a short visit where you then put in your CPT codes, your billing, and orders when the system comes back up. But it's basically having some sort of pen and paper backup. There are not standalone EHR systems. There are some standalone EHR systems, but they don't integrate with the big systems.
Well, pretty soon we're going to have to send even controlled drugs electronically. They won't even take paper prescriptions anymore.
Actually, 1 year from this coming January, there is going to be new regulations on controlled drugs, and the current methodology that is currently being used is going to switch to a more pharmaceutical, pharmacy-based system, and you're going to have to recertify yourself with DEA and go through that whole goat rope of controlled medication prescriptions. This coming January, radiologists are going to want to have a AUC, which is a user authorization code, to do an MRI or a CAT scan. And they will still get paid without that code on that order. But a year from now, a year from this coming January, it will be mandatory. The radiologist won't get paid unless they have that AUC code. Those are being integrated now into EHR systems, but they're not there in all the systems. And that means going to a different app or vendor, put in the data to justify doing that particular procedure, getting the code that says, yes, this is an authorized procedure, no, this is not an authorized procedure, or no, you don't need an AUC code. But in this year, from this January to next January, even if you don't put that code on the radiologist, CMS will still put a little ding mark that doesn't count against you, but yeah, it does count against you for this next year. Whole other issues.
Retirement is imminent at this point.
All right, any other questions? If not, thank you very much.
Thanks, Jay.
It's time to go.
Very good. You and I won't be practicing. Mine will get retirement. Walk in the room and make eye contact.
Oh, I know.
And now,
I agree with you there.
Scuba drivers, you get a 5-star rating. Every month, you get from the